evening, everyone, and thanks for joining me for my talk on disparities in breast cancer survivorship. I'd like to disclose that I serve on the Speakers Bureau for Genentech. The objectives of the talk are going to be to define cancer survivorship and list some of the statistics, describe the important elements of survivorship care, identify disparities in breast cancer survivorship by reviewing some of the literature, and consider some future focus for equitable survivorship care. The poll question is, compared to their white counterparts, Black women are what percentage more likely to die from breast cancer? A, 16%, B, 23%, C, 40%, or D, 57%. Thanks so much for participating in this poll question, and we'll see the answer to this question towards the middle of the presentation. So who is a cancer survivor? It's any individual that has been diagnosed with cancer, and this label begins at the moment of diagnosis and continues through the remainder of life. However, if you think about survivorship care in clinics, the focus is often on those long-term cancer survivors who have completed their active treatment and are being monitored for any recurrence. Cancer survivors include not just those living with cancer, but those also free of cancer. Beyond the patient, we also want to focus on caregivers, families, and friends, because these patients or these caregivers are often facing similar problems to the survivors. Everything from the emotional anxieties of dealing with this disease to having issues with loss of appetite, decreased weight, and lost income. And just as the survivors' needs change, so do the caregivers. However, unfortunately, only about 1/6 report having talked to someone about their needs or having any resources addressed when they are needed. In terms of some survivorship stats, we do know that the number of cancer survivors is rapidly increasing, and that right now they make up about 5% of the population, with 16.9 million cancer survivors in the US. And that number is projected to increase to about 21.7 million by 2029, because we know that our cancer survivors are living longer than ever before. 67% have survived 5+ years, 45% over 10 years, and 18% are alive 20 years after their diagnosis. What about age? We do know that about 2/3 of our survivors are currently age 65 or older. At that time, when they're facing issues such as retirement, financial concerns, and other health issues. About 20% are in that age of 40 to 60, in their mid-career and often raising a family. And our childhood survivors are facing very different issues. They're dealing with issues such as fertility, employment, as well as the late and long-term effects of their therapy. The most common cancer survivors are female breast cancer survivors, followed closely by prostate cancer survivors. You also see a number of colorectal, GYN, and melanoma survivors, and then a mishmash of all the other cancers. The 5-year relative cancer survival increased from 39% to 70% for whites, where unfortunately for Blacks, it lags behind, increasing from 27% to 64%. And for breast cancer, the 5-year survival also lags behind, 92% for whites and 83% for Blacks. What about some survivor trends? We do know that survivors are living longer due to the fact that we have better and expanded screening practice, as well as more advanced multimodal treatment. The population is aging, which is going to lead to more cancers diagnosed, with the expectation by 2040, 73% of survivors will be over the age of 65. And it is also becoming more ethnically diverse, By 2050, we expect that 35% of the population will be Latino and 25% Black. When we think about the stages of survivorship, when we begin with the acute stage, the living with cancer, which is when that initial diagnosis and the treatment is taking place, and patients are working on getting rid or controlling their disease. In the extended stage, the living through cancer, this is immediately following the end of their active treatment, where patients are now adjusting to a new normal. And then that permanent stage of living beyond cancer is after treatment has ended. This is a long-term survivorship where you're watchfully waiting and providing permanent survivorship care. At this point, patients are cancer-free, but they may be dealing with the long-term and the late effects of their treatment. Patients with metastatic cancer are survivors with very specific needs who are often permanently in the acute stage of their disease. A poll by Lance Armstrong Foundation found that survivors are dealing with a myriad of issues. Over 50% are dealing with chronic pain, dealing with the emotional consequences of their cancer, or with the loss of sexual desire or sexual function, while 70% concerns with depression, and then financial issues such as being trapped in a job or dealing with debt can be a big problem with survivors, as well as about a third dealing with infertility. There was a pivotal report by the Institute of Medicine in 2006 called From Cancer Patient to Cancer Survivor, Loss in Transition, which really drew attention to the fact that many survivors were dealing with issues once their active treatment ended, and that we in the oncology world were very poor at providing PCPs and other providers with guidance and understanding of the long-term side effects of cancer treatment. And many survivors were transitioning back to their PCPs without seeing their oncologists, as well as having really poor information about how to manage the transition to this long-term survivorship care. Based on this report, the Institute of Medicine made several recommendations, including increasing awareness of late effects of treatment, improving provider communication, and one of the big ones was creating individualized survivorship care plans. Survivorship care plans are detailed documents given to patients at the end of their active treatment, which summarizes their diagnosis and their treatment and provides guidelines for their follow-up care. Now, the survivorship care plans have been shown to aid in improving coordination of care as well as outcomes for survivors. But a review of 14 studies on the usage of these care plans by minorities noted that minority survivors were interested in surviving and obtaining these care plans. However, there was poor communication by the providers on the care plans, very few survivorship specialists available to them, and sporadic access to and delivery of the care plans to our minority patients. The COC did set standards for survivorship care, and based on these standards, nationally, people were recommended to provide a certain number of care plans. But unfortunately, there was a lot of problems with providing these care plans, and due to that, there was new standards that were set. And now the recommendation is, rather than focusing on the care plans, is setting parameters around the usage of the care plans by each individual institution, and rather really identifying and developing programs, services that meets the needs of the survivors, everything from financial support to rehabilitation and education, and then evaluating the impact of the services that are provided on an annual basis. When we think about survivorship care, there are key elements. It is a multidisciplinary effort and requires a variety of specialists to manage the symptoms and really focus on improving the quality of life of our survivors. The focus in survivorship care is on health and well-being. everything from monitoring for recurrent disease to making sure that patients participate in prevention and screening, not only for new cancers, for other illnesses, and then monitoring and managing the medical and psychosocial late and long-term effects of treatment, as well as making sure that we have great communication between the specialists and the primary care providers so that there's no duplication of efforts and we meet all the needs of our survivors. The scope of services goes from providing a physical exam and history to making sure that patients are managing and we are identifying any side effects of treatment, and then providing resources for those late and long-term effects, as well as focusing on education and referrals as needed. Psychosocially, we want to look at addressing and asking about any distress. Fear recurrence is very common in our survivors, as well as anxiety and depression. Talking about body image issues, as well as addressing relationship and sexual health issues and financial concerns. Survivorship care clinics can have a variety of programs. There are some programs that are led by oncology nurse practitioners, now providing long-term care for survivors. There are programs that are primary care survivors working in a shared clinic with the oncology team. Or there are programs that are focused on the oncology team monitoring and caring for the patient. Whichever clinic is available to patients, one of the ways to figure out whether the patients are able to change or transition to those clinics is by looking at survivorship risk stratification. And those patients that have a lower risk of recurrence and had less intensive treatment, maybe those can be followed closely by the APN or PCP-led clinics on a sooner basis, where those that have a higher risk of recurrence and may have more issues with late effects may be better served by being followed by the oncology-led team. Let's talk a little bit now about some of the disparities in breast survivorship care by reviewing some of the literature. Now, this is the answer to the poll question that Black women are more likely to die from breast cancer than any other group, and they are 40% more likely to die from this disease than their white counterparts. So why do Black women have lower breast survival? As has been reviewed by previous speakers, there is unequal access to quality care for a number of reasons, including insurance. There can also be disparities in timely screening and diagnostic testing for our survivors. Literature has shown that our minority survivors may take longer to follow up with any abnormal findings. There's also Black women have a 54% chance of having localized breast cancers versus 64% in whites. We've had previous speakers talk about triple negative, more aggressive tumor biology in our Black survivors, as well as the myriad of socioeconomic and other social determinants of health that provide competing barriers to care for our providers, for our survivors. And finally, that there are comorbid conditions and obesity, which can lead to lower survival. The disparities for Black women go throughout the cancer continuum. And we know that the care that these women receive in the living beyond, in that long-term phase of their survivorship trajectory, is also fraught with inequitable care. Everything from having poor communication with their providers, lacking the support services that they may need for their follow-up care, and also limits to the access to care. In one study, Black survivors particularly noted less access to post-treatment care that was culturally appropriate to them. There's also disparities in screening and preventive care. Studies have noted that elder Black and unmarried survivors are less likely to obtain annual mammography, that Black breast cancer survivors are less likely to receive preventive survivorship care and monitoring, such as things for their monitoring their cholesterol, their bone density, and their flu vaccinations. The Blacks and Latinos are less likely to adhere to survivorship care clinic visits, as well as mammography guidelines, and that Blacks are 3 times more likely to report at least one barrier to follow-up care compared to their white counterparts. So what are some of these barriers to their follow-up care? Everything from not being able to afford the out-of-pocket costs of their care, 28% versus 51% in Black survivors. Their healthcare costs, 45% in Black survivors versus 21% in whites. This can include things like paying for their medications, anxiety and worry, more common in Blacks, as well as issues with transportation to get to their care. There's also financial burdens of survivorship care, which is higher in our Black women. They are reporting a higher burden of their care, 58% in Blacks versus whites, as well as dealing with issues with loss of income, the cost of their care, again, transportation and loss of job and insurance. Minority women have been found to take longer to return to work, as well as having a higher percentage of losing their jobs after their diagnosis. And being Black and older and having poor health increases the risk of these women not returning to their jobs. Healthy living and breast survivorship can also be issues. Maintaining a healthy weight and being physically active are suggested to be poorer in our Black survivors. They are more likely to be obese, fat plus years after their diagnosis, less likely to follow the recommended physical activity guidelines, and unfortunately have a higher risk of dying from other causes, as well as from their breast cancer. Quality of life can also be an issue for our minority women, who tend to have more symptoms than their white counterparts. There was a meta-analysis reviewing sleep disturbances, which was worse at home for Blacks, not only in the continuity of sleep, but also the duration of sleep compared to the white counterparts. And this led to more issues with depression and fatigue. Chronic pain can affect up to 60% of survivors, and tended to be in the literature more common and severe in Black survivors, though those Black survivors who had higher spirituality tended to have decreased pain severity. And finally, other symptoms also more commonly found in Black survivors included lymphedema, as well as issues with fatigue and depression. So as we think about all these issues that we discuss in the continuity of care, in the trajectory of survivorship care for our survivors, we need to start looking at future focus to improve equitable care. Looking at research that can address those concerns that our minority survivorship patients face, identifying some of the novel strategies to address the barriers to care that we noted for survivors, and as well as those barriers to living after cancer and accessing survivorship care. Trying to really understand the negative impacts that quality of life issues have for our survivors, and how can we identify culturally competent resources to help address these issues. How can we improve communication between providers and our minority survivors so that they understand the issues to look out for, as well as the things that they need to do to maintain a healthy weight, healthy living? How can we empower our cancer survivors with education about their disease, talk about signs of potential recurrence, and then really identify ways to reduce recurrent or de novo cancer risk? And finally, consider community-based survivorship programs to make these survivorship care in clinics more accessible to the underserved, such as our Black survivors.